I'd like to thank everyone for being here. My name's Grant Rigney. I'm a scholar at FREOPP, a visiting scholar, and get to moderate this wonderful panel today on reducing healthcare costs and prices. You all are here, so I don't need to give much of an introduction to how big of a problem this is. It's a problem on the order of $4 trillion, or roughly 20% of our GDP, about $13,000 per person per year in the U.S. that we spend on healthcare. It's grown from 10% of our GDP, and it's almost double that now. We've tried things from fee-for-service and different payment models with capitated payments and different organizational structures with ACOs and preferred provider organizations, all with differential effects and continue to have rising healthcare costs. And the big question of this panel and a big question facing our healthcare system now is how do we reduce costs without sacrificing access or quality to healthcare? So we're not supposed to do huge introductions, but I'd love if everyone could just kind of say who you are and where you're coming from, and just briefly talk about whether or not we're in a cost crisis right now in the healthcare system.
Thank you, Grant. I'm Ji Bai from Johns Hopkins Carey Business School. I'm an accounting professor there. I'm also a professor of health policy and management at Johns Hopkins Bloomberg School of Public Health. So I study healthcare dollars, and yes, we are in a cost crisis, a lot of excess cost. Thank you, Grant.
Hey, Joel White. I'm the president of the Council for Affordable Health Coverage. It is a multi-stakeholder advocacy coalition dedicated to more affordable coverage. The answer is yes, we are in a cost crisis, fiscally and for consumers and for employers. And I think politically it's the number one top of mind voter concern in healthcare right now.
Great. Brian Blase. I am the president of Paragon Health Institute. And I'm going to give a slightly longer answer than G and Joel since I get to go last. Why do we have rising healthcare prices and high healthcare prices? Well, if you go back to basic economics, there's two sides of the market. There's the demand side and the supply side. So start on the demand side. We have enormous tax preferences for health care and health insurance spending, led by the exclusion for employer-sponsored insurance. We've added tax credits in Obamacare. So the government is incentivizing the purchase of comprehensive health insurance, which leads to less sensitivity if you have third-party payment for just about everything that we consume in healthcare. We also have major entitlement programs that increase spending. So we have Medicare and Medicaid. Medicare, historically, if a claim is submitted, Medicare pays for it, no questions asked. And Medicaid, if states make healthcare expenditures for enrollees, the federal government matches it. Both of those subsidies are open-ended subsidies, so there's no limit that Washington places on those structures. We also have the supply side of the market, and what does government do on the supply side of the market? It restricts providers' ability to practice to the top of their license. It prevents entrance into markets with things like certificate of need laws. So we have government inflating demand, restricting supply, and as a result, we have significantly high prices. Now, high prices, in a free market, high prices are not a bad thing, right? High prices signify high value, and they provide incentives for suppliers to come in and provide products that consumers value, and to do so in a less costly, more efficient way. But we don't have a free market in healthcare. 85% of spending in healthcare is controlled in some way or another by the government. So high prices in healthcare are a significant and growing problem.
Yes, we'd love to get the other two panelists' take on why prices are so high in the healthcare system right now as well.
I would agree with most of what Brian said. I think that there's a nuance that I would add to it, and that is on the demand side. If you think about your own health, we want more health care in general. We want to live longer. We want to be healthier. We want to address the cancer aggressively and do anything it takes to cut it out or to be rid of it. And so we're willing to spend a lot more on healthcare than we are on, say, plastic garbage bags or televisions. So the consumer factor here is kind of a unbridled racehorse that without appropriate incentives will consume more and more and more. And so one of the challenges that we see now is that as we subsidize more healthcare, we see higher prices. And I think in particular in Obamacare, what we've seen is that as we've subsidized premiums, and to a certain extent in Part D and Medicare Advantage, the more we subsidize premiums, the higher those premiums go. And so prices for this comprehensive coverage tends to go up as we shift those costs onto taxpayers. In the employer market, where the subsidy is much less, the employer exclusion is much less, what we see is a lot of offloading of those costs onto the consumer. And I think we see smarter consumers as a result. We see wiser benefit decisions on behalf of employers. But we also see tight labor markets where employers are using benefit structures to attract scarce workers to fill unmet needs. So there's tensions in the market. It's pretty nuanced. But in general, what we have is highly uncompetitive markets. The example I use is you could drive from here today all the way to Seattle and never drive through a competitive hospital market in this country. Not a single one. 93% of all hospital markets are concentrated or highly concentrated according to the FTC. What does that mean? It means higher prices, less access, less virtuous pressure on generating quality and good outcomes. And that's largely the result of government policy.
Great. I just want to quickly add that I believe the major reason of the high healthcare costs is policy failure. We have one after another policy failures, and they lead to consolidation, one of the consequences. So once providers have consolidated power, they will jack up the price, right? So let's think about the example. 340B program, right? If I'm a physician practice, I want to join a hospital because that will immediately give me 340B benefit. Right now, and also nonprofit hospitals, all sorts of exemption. If I'm a physician practice, I join a nonprofit hospital, guess what? My practice, the property tax, we exempted, and all sorts of other things, right? And also we have the certificate of needs laws, CON laws, many states, right? In order to start my practice, I need to somehow bribe the whole regulatory process, which has already been captured by the incumbent hospital. So it's very hard. Then we have at ACO, right? ACO is such a failure, really hasn't really saved the money. But guess what? They create a huge incentive for providers to consolidate, to take advantage of the program savings, so-called savings that can channel to the providers. And then we also have the non-site neutral payment, right? If I'm a physician, I would love to join the hospital. Now we already got the report out that physician owned by a hospital, actually, they got a higher payment, 3.2% if I remember correctly. Why? Because of facility fee, right? Facility fee there, same service, different sites, pay different amount. So that's another example. And also we have the, also physician-owned hospitals, they can, right? Because of ACA regulation, we cannot have establish the new physician-owned hospital. So these kind of government policy failures create a very consolidated market, basically making the life of small ones very hard and making the life of bigger ones easier. And then beyond that, beyond this consolidation, motivation for consolidation, we also have as Brian and Joe said, the supply side issue. That is to detach payers from the consumer, right? Detach them, then through a subsidy, through expansion of all sorts of services under insurance, so the consumers don't feel the skin in the game. So as a result, that we see, ACA premium increased by more than double the past decade. So those are results. Many people say that's great, but I would say fundamentally it's really government failure that allow players to take advantage of those opportunities and to be greedy, to make money, to increase the price, benefit themselves. Thank you.
Yeah, so I'm hearing a few different threads here that consolidation is driving up prices, making things less competitive. There's less market forces driving down prices. I'm hearing that government subsidies are trying to subsidize health plans is driving up premiums and prices. And I'm hearing that government spends, sets prices for about 85% of our healthcare system in some way or another. So I wonder if you can provide some clarity on how I want to go back to the government spending, setting the prices and raising the prices for a large part of our system. How is that happening? What's the government doing? Is it Medicare and Medicaid dollars that are increasing rates to providers that's driving the increasing cost? Is it these subsidies? What do you think is really driving the lion's share of the increasing cost here?
So my background is I worked on Capitol Hill for 12 years, spent most of that time at the Ways and Means Committee, and helped enact 9 different laws. And those laws were changing payments for physicians, hospitals, post-acute care. And then we did a novel thing back in 2003. We created this thing called Medicare Part D. And it was novel because we said, we're not going to determine the price. In fact, we're going to prevent HHS from interfering in price negotiations between plans and manufacturers and pharmacies. And people said that we were crazy, right? They said, this will never take off. There's no such thing as drug-only insurance in the marketplace. It's like haircut insurance, right? Like you're going to lose money or you're going to charge a premium that's $1 more than the haircut. I didn't know what they were talking about because I'm bald. It's okay, I know it. But it worked. And the reason it worked is that we relied on plans to bid, and we tied their bids to a subsidy that said if you were more efficient, you'd pick up more market share. Some people call that premium support. And the idea on the Part D side was to take that model and spread it to all of Medicare fee-for-service so that we would get away from administered pricing. And the reason administered pricing doesn't work is that we've got Congress has to change the law to set the formula for how the price is fixed. And then we have bureaucrats, 120,000 at CMS, working on figuring out what's the right price to set based on the formula in 3,800 counties around the country. And they always get it wrong. They never get it right. So price setting is a failure, but we also didn't learn the lesson from Part D that we should really move into more competitively set bids and taxpayer subsidies as a result. The other thing I would just say is that to Guy's point, is that we've tried this adventure in value-based care in Medicare, and we said, okay, we're going to start sharing savings. And if you go at risk for the outcome or cost of the patient, we're going to allow you to save some money. And the problem with those models is that they're incredibly complicated. They're incredibly burdensome on the provider. They're micromanaging the value-based care arrangement. So they may have the incentives right, but the process that the provider participates in is all wrong. And then the second thing is it's kind of like two sides of a triangle where the taxpayer gets some savings and the provider gets some savings, but the patient isn't in the mix. In fact, the patient may not even know that they're in a value-based care arrangement. So if you're not incentivizing the patient to engage in that value-based care arrangement, you're not going to get traction on the value, which is lower costs and higher quality. So as we think about flexing things up, I think we need to move towards more Part D type models and build the consumer into the value-based care equation so that we move away from the administered pricing, which always gets set wrong.
Just to emphasize, I think Joel's really profound point that Medicare, CMS sets all these prices and it doesn't get a single one of them right. I mean, we are often asked, does Medicare overpay for services? Does Medicare underpay for services? And the answer is both. It overpays for some services, and sort of a classic example is it was overpaying for certain cardiac procedures. So you have a lot of these specialty cardiac hospitals emerge and just put lots of stents in people that were unnecessary, but that was what the incentive from the payment structure was. You also have real clear examples where Medicare underpays. We don't have nearly enough geriatricians in this country who would sort of treat a senior's entire health, primary health needs, because Medicare has historically underpaid for geriatricians and that type of services. And it goes back, the way that Medicare sets these prices, it consults with, it gets recommendations from a group of medical doctors, and the medical doctors are just trying to figure out, and the formula is just about what the cost is for providing those services, how much time it takes, how intensive. It has nothing to do with the value of those services. So it's completely ignoring a huge part of the way that prices are set throughout the rest of the economy. Unfortunately, a lot of the private sector bases their reimbursements on the way that Medicare pays, and Medicare pays somewhat differently for hospital care. But you have sort of the power of Medicare amplified by the way that private payers pay throughout the country, in a way that we've got a huge misallocation of resources, and where decisions are made not on what's the best for the consumer, but which interest group has the most lobbying power. So the most lobbied industry in the country is the healthcare industry, and it's largely around these payment rules that Joel mentioned, both for Congress and then for CMS when CMS is doing its revisions and updates to the payment rules.
Can I just make two add-on points here? So the first is that we talk about the prices, and they always get it wrong, right, on the upside and the downside. It's also tied to utilization, and that's tied to quality reporting. And so a doctor and Medicare will deliver a service, and they've got to report on the quality, and that's tied to a measure. And that measure looks at, is it overuse, is it underuse, or is it misuse? So an example of underuse is mammography screening. Like, we want to encourage mammography screening, right, based on the latest science. Misuse is something like we prescribed an antibiotic for a viral infection. Antibiotics don't work on viral infections, right? And so those measures are developed through a quality industrial complex that has now generated 90% of the measures in the Medicare program are not tied to overuse. They're tied to underuse and misuse. So what that means is the quality measures themselves are driving volume of services, which then get multiplied against the price, which then leads to higher spending. And I forgot my second point, and it's Guy's turn anyway.
Thank you, Joe. I just want to bring some numbers here. So think about the COVID testing, hospital CPR test. We published a paper in Journal of General Internal Medicine 2 years ago and have an opinion piece on Wall Street Journal regarding how much government has been overspending on COVID testing. So in Hawaii, Medicaid pays $100 per test. Medicare pays $55 per test. Guess what? The cost, even if you add all the facilities, the hospitals, overhead in, at most $20. At most, conservatively, it would be $3 or $4 for that test. So that's how government overspending. Another example, think about generic drugs. So we just published a paper on JAMA Health Forum. We look at the most utilized 45 generic drugs. For every $100 spent by Medicare Part D, $40 go to PBM spread pricing. $30 go to manufacturers' gross revenue. All right, so $40, among the 100, 40 goes to spread pricing, just spread pricing, gross profit, and 30 as a revenue to manufacturer. Then the manufacturer cannot make 30, right? Because manufacturers still have manufacturing costs, etc. So that tells us how much is a waste, is a complexity of the administration, complexity of insurance adding to the system. That's why we have Mark Cuban, Cost Plus Company, we have GoodRx. These providers are able to bring the cost so much lower than even many patients out-of-pocket cost. So just want to bring some data points here.
All right, so I want to leave time to talk about how we can reduce prices in healthcare instead of just talking about why they're high. So maybe on that point, we can start with some recent legislation that's passed in the IRA and talking about Medicare drug pricing negotiations. A lot of people think this is going to be transformative. Some people think it's going to have very minimal effects. You know, drug spending is maybe 15% of overall healthcare spending. So love to get your thoughts on how important is the Medicare drug pricing negotiations? Is it going to have an effect? Is it actually going to help? Is there something else that we should be doing that's going to help a lot more?
So, yeah, just quickly, I was a visiting scholar at CBO for a year. So this actually is on top of CBO's agenda. You know, they really need to know exactly how much is the impact of the IRA on new drug development, because they had an estimation, right, on the number of new drugs that will be reduced because of IRA. But now they, you know, so I would say CBO probably got it right. Number of drugs will drop, but then the question is exactly how many. And that, you know, once we have the concrete evidence, that will help CBO and also help, you know, legislative body to understand the impact. Thank you.
So it's going to have a profound impact. I think the biggest thing that I think about is that we've kind of crossed a threshold into more of a European-style government-run model for setting prices, and the political calls to expand that model dramatically in Medicare and then apply it to the commercial market where 153 million people get their coverage is troubling. And the reason it's troubling is that we have decades of experience on these models all around the globe. And it's not just like Canada to the north, Europe, South Korea, Taiwan. Every country that has tried this has seen the same thing. The first is less patient access to products. There's less innovation, so innovative products typically don't get launched in those countries, and that has a profound impact on health, largely because if you've got 50% of the cancer therapies in England than you do in the United States, for example, which is the current situation, you have fewer opportunities to treat and cure that disease. What does that mean? It means you have more spending on emergency room visits, more hospitalizations, more hospice spending, et cetera. So really the pathway towards lower costs, I think, is in market discipline on prices. And so you can either choose the IRA, which is price setting, or you can choose markets, or kind of a combination of the two. But the thing I don't think CBO did a good job of taking into account is that they were the most pessimistic. Every expert says there'd be fewer products. Okay, that's not in dispute. It's just CBO said 2 fewer. Okay, and some people say hundreds fewer. And we've already had 3 products pulled from the clinical trials in the marketplace, and the price controls aren't even in effect yet. So I think CBO is kind of at the low end. But those 2 products not getting developed means for those indications, you will have more hospitalizations, more ER, more hospice, more whatever it is, right? Like there'll be attendant spending on the health services side. So, and then finally, I would say that, remember, this isn't just on the pill side, it's on the medically managed drugs, so biologics, infused, injectables, et cetera. That's in physician world, okay? And what it basically means in Medicare is you're gonna cut their drug payment by 50%. In the community setting, so community oncologists, community cardiologists, urologists, et cetera, they can't survive in the market without joining a mega physician practice or a health system. So the IRA may lower taxpayer costs on drugs, but through consolidation, it will increase hospital spending and reduce access in the community to some of this highly specialized care, which is going to be a big problem as we face physician shortages and an increasingly constrained fiscal environment.
I guess a few points. One, when I was in the White House and we were looking at the problem of rising drug prices, we looked at this measure of inflation, CPI-RX, and actually drug prices overall had fallen for several years, 2017 and 2018. And a large part of the reason is the Americans consume more generics than any other country. 90% of the drugs that Americans consume are generics. We have a very robust generic market. I think where there are sort of clear problems in government payment policy would be not Part D, but Part B, where we have an inflationary payment structure, which is for those infused drugs that are provided, the price is average sales price plus 6%. So there's an incentive to provide higher cost drugs. And I think that's something to look at, how we could get more of Part D discipline into Part B. I will say there's another aspect of the Inflation Reduction Act on healthcare, which is definitely inflationary. There was a big expansion of subsidies for Affordable Care Act plans. So the ACA, if you don't get coverage through your employer and you buy in the individual market, there are tax credits, and the tax credits are structured to limit the amount of income that a household has to pay for a benchmark plan. And originally, they were capped at 400% of the poverty line. There was a problem with this structure. When the premium goes up by $1, the subsidy goes up by $1. So over time, as premiums increase, the taxpayer bears the entire cost of the premium increase. The ACA, the Inflation Reduction Act made this worse because it increased the generosity of the subsidy for everybody who received one and lifted the cap at 400% of the poverty line. And there are some places in the country where you can have households that make $300,000 that receive significant taxpayer assistance to buy ACA plans because of the subsidy expansion. Now, fortunately, those subsidies are only enhanced through 2025. So one of the reforms going forward has to be how to come up with either let those enhanced subsidies expire, or come up with a different structure that is not as inflationary.
You guys passed the microphone through me, so I'm just going to keep jumping in. Well, drug pricing is important, right? Because it's not just drug pricing, right? Like, this is the tip of the spear for public option or government-run healthcare, and that is, if we can price control the drugs, what about hospital services, which is 3 times as large as drug spend? What about physician services? And then you hire the plans to just administer those administratively set prices. And I think the challenge here is that the political call for price controls on drugs was so loud because it's the point of the healthcare system that we access the most, right? You're not going to the hospital every month or hopefully you're not, to get coverage or to get care, but you're going to the pharmacy every month to pick up a prescription, or you're having it mailed to you, and you're paying your cost sharing on that. And this is where I think the intersection of coverage and costs collide most frequently. 92% of all Americans have some form of health coverage. All right, that means 30 million are kind of out. And who are those people? Well, 20 million are eligible but not enrolled. So who are the 10 million? Well, 2.3 are in Medicaid non-expansion states, and another 2.5 are incomes above 600% of poverty. They're rich people who are opting out. Okay, I don't care about them. And then the remainder are here illegally. So that's more of an immigration type issue than a healthcare challenge, although it's a healthcare challenge as well. So as those people were brought into the system, they had coverage, and their plans were requiring different cost sharing at the pharmacy. And increasingly what we've seen is aggressive formulary tactics that shift from dollar copays to coinsurance. Well, if I'm paying 50% on a product, I'm more outraged than if I'm paying $20. And the second thing that I think is important on the coverage side is that cost sharing typically applies against the gross cost of the drug, not the net cost. So as Guy pointed out, like, if you've got a $100 product and $50 of that $100 product is a price discount to the plan that's not passed through to the consumer, my 20% is on the 100, not the 50, I'd be pretty pissed too. And I tell you, pharma is pissed that they're getting blamed for the $100 when they're only making 30 back, according to your research. So it is a political problem as much as it is a market and a policy challenge.
May I add one thing quickly? It's about there's an underappreciated impact of RA on drug shortage. So we have a pretty bad generic drug shortages, right? Many drugs, especially like antibiotics, some very commonly used low-cost drugs, we're facing shortages. Actually, the RA will likely worsen that problem. Why? Because they asked Medicare to have impose this inflationary penalty on drug manufacturers. Think about it, in a free market, if there's a shortage, manufacturers sense the signal. What would they do? Right? If I'm a manufacturer, I know there's gonna be a shortage. I'm gonna do two things, right? Number one, increase my price. Number two, increase my production. And once the two things happen, then we will reach an equilibrium because I'm not the only one doing the game, right? Other people will do the same. Then we have expanded the production, and the price will get up, but won't be forever. Because if I keep doing that, I'll be priced out of market. That's how the market regulates the whole system. And then the price will reach equilibrium, actually will go back, and we have expanded production, everybody will be happy. But now once we have the inflationary rebate on generic drugs, guess what? If I'm a manufacturer, I was like, who cares, right? I can, if I increase my price, I will get a penalty. I will not do that. Then I won't really have the incentive to increase production. Then we end up we'll have more and more shortage, especially for low-cost generics. That's just one underappreciated point. Thank you.
We'll have time for questions in just a minute. We'll do one more question here with the panel, and then we'll go to questions to close it out. A lot about prices here and the value of knowing prices. Price transparency is a relatively new concept in healthcare. I know you've worked on that quite a bit. Would love to hear from you all about the effect of price transparency on overall costs in the market. We know Medicare, Medicaid prices. Those are published. Now hospitals and insurance companies are supposed to report those as well, although with varied compliance, is my understanding. So would love for you all to comment on that before we go to questions.
All right.
The master.
So I actually did a paper for Grace Marie at the Galen Institute on what I thought would be the effects of price transparency, and I thought there were 4 positive effects of consumers knowing prices in advance, and consumers being both individuals as well as employers who purchase so much of the nation's healthcare. One is it eases consumers' ability to comparison shop, and we've seen examples where people have price information. They do shop for services that they're able to shop for, and about half of all healthcare spending falls into this bucket of shoppable services. I think a second real benefit of price transparency is to help employers design better benefit structures. So one of the benefit structures that I really like, some call it reference pricing. Michael Cannon has a book out where he calls it the reverse deductible. Michael Cannon with a new book out last week that I just read in preparation for a discussion we're having later today. But under this model, the plan sets a payment rate, and that's it. So if a consumer goes to a provider that charges more than that amount, they're responsible for the difference. And they do this, California did this for its public employees and retirees. Safeway did this for labs and imaging. And what we found is when consumers had this incentive, they shopped. That isn't surprising. But what happened next is the best part of the story. The high-priced providers didn't want to lose their customer base, so they decreased prices considerably by, I think, Michael, correct me, but like 20 to 30% on average. So all the plan had to do was set the payment rate and provide sort of the information about what the different prices were, and through sort of the normal people voted with their pocketbooks, you had a profoundly positive effect on the supply side of the market.
Yeah, I think the way I think about it is there's 2 kinds of transparency. The first is kind of like, let's put all our prices on a website and someone can go in and take a look. The other is kind of which I'm excited about. The second kind is kind of point of care decision support. These are like, people call them real-time benefit tools. Again, keep in mind, 92% have some form of coverage. So how does the price fit into my current cost-sharing obligations, right? And that's what the data and technology is now able to reveal at the point of prescribing for a service or a drug, and at the point of dispensing for delivery of care or prescription. And the evidence is pretty encouraging. Most health plans have these tools. The evidence shows that it does drive down costs. It increases generic substitution. It allows people to choose lower cost services. So one gets at the provider level, what do I choose? The other is point of care, actionable kind of intelligence. But I think the thing that, as I think about PBM transparency, hospital transparency, insurance coverage transparency, like there's a lot of compliance that's going to get built into this, a lot of costs that will get passed on to consumers, and so it'll be, regulatorily difficult. But I think what we're missing in the discussion is that there ought to be an incentive tied to the consumer so that they choose a lower cost provider, whether it's a rebate on your cost sharing or a lower premium or a discount on your premium, or what Brian and Michael are talking about. There's a company actually out of Ohio called Sidecar Health that does this model in the marketplace. They wanted to get into Obamacare, but CMS said, your network doesn't work for our program. They don't have a network. You can go see literally any doctor you want, and as Brian said, if you see the expensive one, you got to pay the difference. If you see the cheaper one, you literally get a check in the mail. They said you don't define a network, so we can't make that work. It's the most open network literally on the planet. Unfortunately, CMS said that was too open for them.
Thank you. So I want to make 3 points. Number one, I think price transparency is very powerful, but it's not panacea. If I don't pay, I'm a consumer, I don't have skin in the game, I don't care, right? Even if you put the price in front of me, I don't care because I don't pay. Second, think about the primary users or purported users of price transparency, employers. Employers have two fundamental structural problems that prevent them from being very efficient purchaser. Number one, they don't have meaningful purchasing power in most markets. Not meaningful, right? Unless you're UAW in Michigan, that's a special case. Second, the person who's in charge of purchasing the health plan, health benefit, is not the person who pay, which will be the consumer and to a large extent the employer. So you have three parties all separate out, right? The HR person whose pay will not be affected by whether efficient or not. Very, very little, very low power incentive for the HR person. And then you have the employer who's paying but who does not enjoy the benefit directly. Then you have the employee. So this separation of those three parties will make it very inefficient. So that's why I think there's some fundamental structural issues on the employer market we have to address before price transparency can be very effective. Third, think about before the law passed, before any regulation on price transparency, all the ambulatory surgical centers dealing with cash pay patients voluntarily post on their website. So if you go any of the AICs dealing with cash pay patients, you'll see very consumer-friendly price transparency. They show the picture of the part you do surgery, and they give you a bundle payment, including everything, pre-surgery, after surgery, everything. Why? Because their business model dictates that have to disclose price so that they can win market share. So that's why I think in addition to price transparency, we have to make some structural changes so that people care about price. Then we can fully utilize the potential of price transparency. Thank you.
All right, we have a few minutes left, so let's go to some questions. I believe you had a question in the back there.
Sure. I'm curious what you think of some of the comments, what you have made respectively. So, for example, Joel emphasized the financial solvency of oncology practices that comes from the spread pricing on drugs, right, particularly the Part B or infused drugs. Brian criticized it as inflationary. So I'm curious kind of how you square that circle. And then Joel and Brian both talking about the benefits of generic drugs, a large share of the market they pertain to, why that keeps overall spending down. But he came in a couple of times with kind of really broken stuff in the generic market, right? The spread pricing with those expensive generics, the shortages that have occurred, and of course many of those generic drugs do flow through the Part D program. So I'm more curious, like as you were listening to one another, like, how do you resolve those differences in position?
We're not the same person, first off. No, I think my experience on Part B is I've spent a lot of time looking at data, what's happening in particularly community oncology. So remember, before we had ASP, we had AWP, and costs were growing in that market on average by about 30% over a 10-year period. The annual rate right now is less than 5. And what we see is a lot of generics coming into the market. And when those generics come into the market, the take-up of those generics is almost immediate, and it is almost universal. Obvious specific examples that we could point to where that's not true. But in general, the reason is there's a lag between the reimbursement until it catches up to the price. And so there's arbitrage that gets made on the generic side, but it really drives near universal adoption of generics in that marketplace. And, so the 6%, when we created ASP, I was on the team that created ASP, it's an average price across all sales, final, net of price concessions, right? And so some people are above the average, some people are below the average. And so a lot of them join purchasing pools, but on average, MedPAC assumes that people, or has estimated people buy it at about ASP plus 2.5 or thereabouts, okay? So the spread, you say 6%, there's a sequester that sits on top of that. So the actual rate is 4.3. So there's a 2% in there, built in for wastage, spillage, spoilage, office overhead, administration, patient records, et cetera. So as we look at how ASP has fared, it's actually been okay. Now, having said that, Brian raised the point of, well, people have an incentive to overprescribe higher cost drugs. Show me the data. Because I haven't seen it. I've done countless meetings with MedPAC. I've looked at the CMS data. I don't see the utilization breaking that way because of the generic incentives. And the second point I would make is when we did ASP, we had a second model in the law. It was called CAP, the CAP program, Competitive Acquisition Program. It was competitive bidding for the Part B market. And unfortunately, because of some political dynamics, when we wrote that portion of the law, we weren't able to do things like formulary management on stuff because they said we were killing cancer patients and things like that. But so CAP is on the books. It's supposed to be a legal option for providers. CMS has not implemented that program since 2010, 2009, something like that. It should be an option for people so that we can do competitive bidding alongside ASP, and let's figure out which model works better.
Yeah, I mean, I would just say when I look at the design of programs, the focus is how do we align incentives to focus on the value rather than just maximizing spending and revenue for providers. So ASP plus 6% creates bad incentives. I would say on the drug shortage, G is much more into the weeds on that than I am. My experience with that back in 2010 and 2011 when there were shortages of some cancer drugs, I think it's similar to what's happened here, is it part of it is a regulatory problem, and the FDA has taken off a large amount of capacity at facilities that were producing these drugs that were, not produced by other facilities.
So just for the low-cost generic drugs, it's just not efficient to use insurance to cover it, right? And we have a paper first coming in JAMA showing even for OTC that Medicare is paying so much more money for over-the-counter drugs. Like right? Then people can easily buy. If you give them cash to buy over-the-counter, you're going to save so much money, and you can give the money to the people, and then people can just buy social determinant health, right? So yeah, I would say there's already a opinion piece on Wall Street Journal by, I believe, UIC people proposing like low generic drugs out of insurance, because insurance come here to cover high cost, right, service, high cost events, not for those low cost things. You can get $5 per month, Amazon Prime, paying cash for almost all the commonly used generic drugs. Thank you.
I have one question here as well, and then we'll do the rest of the questions after the panel. Well, we have a mic here for you.
This might seem like a stupid question, so bear with me. But you were just singing the praises of how reference-based pricing, they set the level, and if you want a service, you pay more if you want it more expensive. How is that different from the concept of drug price setting? Because forget the IRA because it has like penalties and stuff. But how is that different? Is it that you can't shop around for drugs? Is it that the FDA, all the rules keep cheaper ones from coming on? Because the whole reference-based pricing model is if you're only going to pay this amount, providers will eventually stop.
Price control, the government is saying it is illegal to pay more than this. It is illegal to pay more than this amount, right?
Okay.
The plan is saying we are going to pay this amount. Consumer, you are free to pay whatever you want above and beyond out of your own pocket. You're free to choose any high-priced provider, and the provider can charge a higher price, but there's not any legal mechanism that punishes providers that charge above that price.
But if you set the drug price, wouldn't that encourage competition to bring drugs at lower costs?
Well, I mean, I think whenever you have government imposing price controls, you're going to get sort of all of the negative effects that you get when a price is held below where the market price would be.
So is there any way to
You
do
get shortages
reference-based
and-
pricing in drugs?
What's that?
So
I think
is-
you could do reference pricing in pharmaceuticals, yeah, but it would be the plan. It'd be the plan deciding how much they're going to reimburse for the particular class or the particular pharmaceutical. And consumers could pay more than that out of their own pocket, and they'd have then incentives to shop and economize rather than the plan coming in, rather than the government coming in.
Just real quick, that's what Sidecar does on drugs. So they basically take an average market rate and set that average benchmark, and then up or down, you either pay or you get a rebate.
Thank you.
Thank you.
Yeah, that'll be the end of the official panel. If you have other questions and the panelists are still around, you're welcome to come up and chat. But thank you all. Thanks for being here.